and we can address that quality of sleep. There's technology to do that now. Next, oxygen supplementation can be offered if indicated. So for example, someone can be given extra oxygen to help increase the efficiency of their sleep. The World Health Organization has said that prevention is the most cost-effective strategy. We've all seen reports about how addressing smoking has had a dramatic effect on lung cancer incidence. The PAP test lowered cervical cancer mortality. Some researchers have stated by 70%, some 80%. Of course, this depends on where in the world, at what time. But what is clear is that in the last 50 years, there's been a big improvement, especially now that there's HPV vaccine. There's been a decrease in breast cancer mortality between 1990 and 2015. Of course, this might not simply be because of early detection. It's also because of better treatment. It's also because, perhaps general awareness. All right, so it's not simply the screening itself. It could also be women who are more aware of the symptoms and more aware of their bodies, and who are therefore presenting earlier, making the treatment more successful. But yeah, mammography, we're going to talk about the kind of screening modalities. 39% decrease. It's wonderful. This is a success story. And colorectal cancer is also down 46%. We're going to talk more about that. The point is that health professionals should encourage screening, and those at higher risk should get further screening if indicated. In the recent AACR, there was a presenter who was talking about, it's not simply enough to screen, of course, we have to make sure that the infrastructure is there for adequate treatment for those who are found to have an early stage or pre-cancer. All right, so here's the big three that we can recommend early screening for across the board, right? Cervical cancer for all women from age 21 all the way up to 65. There's benefit, all right? Colorectal cancer from age 45 and breast cancer from age 50. So let's look at a few details here. Starting with cervical cancer. So the first one I would like to mention is the importance of PAP testing for reducing cervical cancer. It reduces the incidence of mortality by 80%. When HPV DNA is combined, okay, HPV DNA testing in cervical smears, it increases the chance of early detection by 30%. And so it's recommended not just the PAP smear, but also the HPV testing. And the US Preventive Services Task Force recommends cervical cancer screening every 3 years with cytology alone. Because when it's combined with the HPV testing, the ability to detect is improved. And so it's possible to have testing only every 5 years. Also, every 3 years, that's from ages 21 to 29, but then the risk lowers slightly, and so it's every 5 years from ages 30 to 65. Now let's look at colorectal cancer. So there's multiple screening methods available. The gold standard is colonoscopy. It should be performed every 10 years, starting from age 50. There's also other possibilities: double contrast barium enema, flexible sigmoidoscopy. There's also smaller screening tests. There's the fecal occult blood test and the FIT, F-I-T, the fecal immunochemical testing. Okay, now these are cheaper options and they might not detect with as high of sensitivity, although the Cologuard the fecal immunochemical testing, Cologuard has reached 92% specificity, which is really good. All right. Of course, it's more expensive than its competitors. So the thing is, when the fecal occult blood testing or the fecal immunochemical testing, flexible sigmoidoscopy, when any of these other screening methods are used, it's important to know that colonoscopy is the fallback, and that's what we use to check whether or not there is a case. Okay, now the other ones are a little bit less invasive. Colonoscopy, there is a risk of perforation, bleeding, even major bleeding, and death is possible. Okay, of course, it's not common. So for example, perhaps perforation might happen 4 in 10,000. Okay, it's not very common. Major bleeding might happen 8 to 8 people in 10,000 people screened. The reason it's recommended for older ages is because at the younger ages, 3 deaths might be prevented between ages 40 and 49, according to the research presented by Croswell and colleagues in 2018. But there might be 6,100 false positives. That leads to not only unnecessary treatment, but also psychological distress. Okay, and expenses as well. Expenses due to the false positives and extra treatment, follow-up. In fact, the diagnosis itself, despite the potential for a cure, there's also the stigma, and people tend to lose their jobs because they're missing work and taking leave, not getting paid while they're off work, and then maybe employers don't want to keep this employee. So women who have breast cancer tend to be unemployed more often than those who do not. I mean, these are some factors that need to be considered as to whether or not to screen. And so as a result of the 3 deaths that have been prevented, there's 700 unnecessary biopsies and 50 overdiagnosed breast cancers. All right, so that's women who are going through treatment who didn't need to go through treatment. Between ages 50 and 59, the situation is looking better. 8 deaths prevented with 6,000 false positives and 950 unnecessary biopsies, 80 overdiagnosed breast cancers. All right, so the good news is that the treatment is not so harmful, and so that starts to become a benefit. But where it's really clear is ages 60 to 69, the breast cancer screening, 21 deaths prevented with less false positives, 5,000 false positives, 1,000 unnecessary biopsies, 120 overdiagnosed breast cancers. I mentioned high risk, that includes smokers. So when a health practitioner has access to good screening programs and good lung cancer treatment, then it becomes recommended to encourage people who have been smoking in the past 15 years, who are currently smoking, to begin their lung cancer screening. Okay, lung cancer screening might save 5 people in 1,000 from death. About 1/3 of the people, however, 365 in 1,000, might experience false positives tests. A 16th of them, about 25 in 1,000, might undergo invasive procedures such as biopsy or surgery. 3 might even suffer complications. So 5 in 1,000 is saved, but 3 are suffering, and it might not be, people who needed any treatment at all. So this is the possible harm of lung cancer, and this is why it should be a decision based on consultation and the person consents to this. Likewise, with family history of breast, gastric, endometrial cancer, colorectal cancer, melanoma, there can be genetic tests conducted, and then genetic counseling can be undertaken. If indicated, there can be further testing.